Next thing we're going to look at is Tussoception is a pattern of permeation where a proximal segment of valve literally permeates into a distal segment of valve. Now, this causes a couple of problems. First of all, it keeps off the blood supply of the valve, so that can cause gangrene. The second thing is it does cause a valve obstruction. Now, the cause of this really depends on age. In an adult, most of the time, tussoception is caused by some sort of polyp that hangs down in the lumen valve. And have a polyp hanging down here, something like that. The peristaltic wave comes down, this proximal segment of the valve grabs hold of this polyp, and then just causes the entire proximal segment of the valve to prolapse the distal segment. As a result, you get this pattern of prolapse we call intussusception. Another cause for intussusception is responsible for this condition in kids. Kids, intussusception is usually caused by hyperperistalsis, very vigorous contraction. Again, you grab hold of a proximal segment, shove it into a distal segment. You get this telescoping action valve, we call it intussusception. So really the etiology is a function of age. All right, let's take a look at what an obstructed valve would look like radiographically. Let's first take a look at normal valve. This is an upper GI series. Okay, we'd allow the variant to go through the entire GI tract. You can see the stomach, of course, over here. You can see approximately this whole valve. You notice the filling defects in the valve, kind of perpendicular to the longitudinal axis of the valve itself. Those are areas of filling defects caused by the case circularis, very large folds in the valve wall, reflection folds in the submucosa, the very large folds that protrude into the lumen and they displace the radiopaque dye. So this valve looks like it's filled with lots of filling defects. They're actually all normal. It just folds in the submucosa, the case circularis. Problem with the valve obstruction is that any air that's generated, any gases that are generated in the valve are supposed to be pushed distally. And when there's an obstruction in the valve, those gases can't be displaced distally and they build up in the valve, causing massive distension. So if this is what normal valve looks like, here's an example of an obstructed valve. Right here. Again, this is upper GI series. You can see, again, the loops of small valve here. You can even see the filling defect still in the case circularis. Now, if you trace the valve through its length, you come to a point where we can't see any valve anymore. This is where the obstruction is. This is a point where the obstruction does not allow any of the contrast agent to travel distally, and that's why you can't see it. But take a look at what you can see. Massive distension. Loops of valve. This is all because gases cannot pass beyond this point. They build up in the valve, they cause incredible pain, incredible distension to the individual. Usually, to deal with something like this, we have to put in some sort of NG tubes, nasogastric tubes, goes up the nose, down the esophagus. Usually, the tip of the tube is positioned in the duodenum, and we apply gentle suction to kind of decompress this valve. Otherwise, the person's in incredible pain. Okay, other forms of valve obstruction. Volvulus, another form of mechanical obstruction. The volvulus is a condition where a loop of valve twists on itself right at the base and causes an obstruction. Usually, it presents with acute onset pain. There are two patterns of volvulus. There's something called typical volvulus, very common in the sigmoid colon, and then there's an axial volvulus, which very often affects a large valve somewhere in the vicinity of the cecum. Let's take a look at the typical volvulus. You can see how a loop of valve can twist right at its base, twists on that base. Obviously, it's going to obstruct the valve. The obstructed bowel, of course, is going to be distended proximally here, and there's a lot of gases that will also build up in the segment of bowel called fluid. Usually something like this develops in older individuals who are chronically constipated. Seems like peristaltic waves are very vigorous in the sigmoid colon. Sometimes peristaltic wave causes the bowel to supercoil, meaning the bowel just twists right at the base, causing this obstruction. Sometimes there is a reason for this to occur. Sometimes part of the sigmoid colon is kind of inherent to each other. A little bit of a connective tissue that's connecting the two segments of sigmoid colon, sometimes not. Whatever be the case, individuals are chronically constipated. Very powerful peristaltic waves kind of cause the super bowel twist on itself. And this can happen. It was typical volvulus pattern. Again, onset of the quite a bit of pain, acute onset. Then we got the axial volvulus. And this is a type of bowel twisting in its own longitudinal axis. You can see there's the cecum, there's the appendix. You can see the ascending bowel here. It looks like a segment of the ascending bowel is twisted in its own longitudinal axis. Of course, you get extension proximal to this, and it looks like you get an incredible degree of obstruction, possibly pinching off a lot of the blood vessels in that area, again, causing
That one's not acute, like pain.
this one does present with pain.
Is it acute as well?
Acute pain, if the bowel twists on itself like that. It hurts. Anything else in this? Okay, sometimes you can identify these different forms of volvulus patterns on a radiograph. Let's take a look at typical volvulus, how it would appear. And you can see we've got the volvulus pattern here, the loop of bowel twisting the face. You can see that segment of bowel that's twisted on its own base in a radiograph. You can see it here, looking at it right here. You can see the outline of the bowel. And it's twisted here at its base. You see nothing but a big air density in between the walls of the bowel, and that's because there's a lot of air building up in that occluded bowel. A lot of gases being generated by bacteria. There's overgrowth. Again, this is causing massive extension in this particular bowel. See it clearly as air density. Again, this happens whether it be the typical pattern or the longitudinal, the axial pattern. It's going to present with an acute onset of abdominal pain. In case of the sigmoid volvulus, you see something that resembles a U. It's called the inverted U sign. All right, so let's talk a little bit again about presenting features of an obstructed bowel. Depending upon the cause of the obstructed bowel, there might be an onset acute pain, volvulus, or something that's going to hurt when that happens. In other cases, there might not be acute pain, but there might be incredible distension associated with the obstructed bowel. And that obstructed bowel continuously becomes distended by accumulating gases. It's going to start to hurt. Now, the bowel is obstructed, so nothing can pass distally. And so typically what will happen is people will start vomiting. Except this vomit will probably be bilious, meaning you'll have bile in it. The contents of the bowel backs up into the stomach when the bowel is obstructed. That includes bile, and the person vomits. You'll notice there's some green bile in the vomit. Usually, if someone is vomiting due to some sort of problem or obstruction proximal to the duodenal sweep, the person will vomit, but the vomit will not contain any bile. That's how you can kind of tell if there is some sort of problem distal to the ampulla or something proximal to the ampulla. So whether there's bile in it, got some sort of obstruction, for example, maybe a pyloric outlet obstruction that's proximal to the ampulla, that's where bile is being injected into the bowel. An obstruction proximal to the ampulla, person vomits, you won't see bile, it won't be bilious. But if there is a problem distal to the ampulla, then there's an opportunity for all of that material to back up to the stomach, the person will vomit something bilious. Okay, any questions on that? Yes. The ampulla, that is where the common bile duct and the pancreatic duct merge. There's the duodenum, there's the ampulla. That's where the pancreatic juices get introduced into the bowel and where the bile is. So if you have an obstruction distal to that, backs up, vomit will be bilious. If you have an obstruction proximal to that, folks have to be bile. Anything else? Let's talk a little bit about functional obstruction. So I presented to you a number of different phenomena that can cause mechanical obstruction of the bowel. We've got patterns of volvulus, we have fecal impaction, we have intussusception. Okay, those are all examples of mechanical obstruction of the bowel. However, sometimes the bowel stops working properly. The bowel stops working, it stops conducting these peristaltic waves, propagating fecal material and gases distally. Sometimes the bowel becomes paralyzed. We call that adynamic ileus. Adynamic ileus. The bowel just stops propagating contents distally, and that's because it's aperistolic for whatever reason. We call that an adynamic ileus. An adynamic ileus is a functional obstruction of the bowel. Nothing can pass distally, everything backs up, just like there's a mechanical obstruction, there's no actual mechanical obstruction, it's a functional obstruction. Sometimes this happens when the bowel is somehow traumatized. For example, during an abdominal operation, after you access the different organs, the first thing that the surgeon's going to do is move the bowel out of the way. Move the bowel out of the way, you kind of traumatize the bowel. And as a result, for a short period of time, the bowel doesn't function properly. It's adynamic, it's aperistolic. And maybe for a day or perhaps two after an operation, person's going to have this condition called adynamic ileus. Eventually, the bowel should recover. Typically, to monitor the function of the bowel, we'll ask the patient, have you passed gas today? If they pass gas, then we know that the bowel's functioning. It's becoming peristaltic. Generally, after an operation, they may become very distended. But again, that should be a transient condition. Once the bowel starts working again, they'll start passing that gas. And we know that peristalsis is restored. Anything else? Okay, that's the case. Let's take a look at tumors of the small and large intestines. We're not going to talk much about tumors of the small bowel. They're relatively uncommon. Most of the time, we'll be focusing on tumors of the large bowel. Tumors of the small bowel, probably too infrequent to bother with. However, the tumors of the large bowel, very common. Most of the tumors of the large bowel will evolve from the epithelium of the large bowel. These are tumors of epithelial origin. The tumors that develop there may be benign, they may be malignant. When they're benign, they're usually presenting the form of some sort of polyp. Of course, the malignant It's usually in the form of an adenocarcinoma. Now, most of these different tumors will develop more in the distal segments of the bowel, especially in the sigmoidal area and the rectum, the rectal wall. Most of the tumors are evolving in that area. Let's take a look at a few of these different types of tumors that develop in the colon and in the rectum. First, we'll start with some of the benign tumors. Start with polyps. A number of different types of polyps. We can subdivide them into non-neoplastic polyps, neoplastic polyps. Let's first talk a little bit about the different morphology of polyps. Okay, polyps usually will present in one of two morphologies, called sessile or pedunculated. Take a look at the sessile first. Here's a depiction of a section through the bowel wall. You've got the lumen of the bowel here. Mucosa, submucosa, the way the muscularis propria. The sessile polyp just presents as kind of a bump on the wall of the bowel. It's this kind of irregularity in the wall of the bowel. That is a polyp with sessile morphology. Another common morphology to see, a polyp, is called pedunculated morphology. Pedunculated morphology has both a stalk and head to it. Here we see a section through the bowel, again, mucosa, submucosa, muscularis propria. Arising from the bowel wall, we see the stalk with a head on the end of it. Okay, this morphology is referred to as pedunculated. This is a polyp of pedunculated morphology. Let's take a look at a few examples of these different polyps. First, we'll start with the non-neoplastic polyps. Non-neoplastic polyps, they have no neoplastic component to them. In fact, they have no malignant potential, meaning they're not going to degenerate into something more. Nonetheless, they can still cause problems. You have a polyp really of any nature, kind of sticking out in the lumen in an exposed position. Sometimes fecal material passing by can excoriate the surface of the polyp, which cause some bleeding. And so one of the problems with polyp is they can bleed excessively, sometimes to the point where they can cause anemia. Another problem with these polyps, even if they're not neoplastic, sometimes they'll get caught by a peristaltic wave, and they can drag a proximal segment of bowel into a distal segment of bowel, resulting in what we call intussusception. Of course, that's going to present some onset of pain, bowel obstruction, and everything we talked about related to mechanical obstruction of the bowel. All right, well, these different polyps, generally, when a polyp develops, chances are it's going to be a non-neoplastic polyp. 90% of polyps are non-neoplastic. They're very prevalent in individuals, particularly over the age of 60. Usually, these polyps will result as a consequence of some abnormal maturation of the GI epithelium. They're related to inflammation. Inflammation develops in the epithelium, won't allow the epithelium to work properly. It over-proliferates and get what we call a hyperplastic polyp. Hyperplastic polyp. Plastic polyps are very common. In other instances, sometimes the polyps are the result of some sort of problem during embryogenesis. There's some sort of lump of disorganized tissue. The cells comprising the tissue are normal. It's just that they're arranged abnormally in architecture. That's called a hamartoma. Sometimes these polyps are hamartomatous. A good example of a hamartoma would be a juvenile polyp. Called juvenile polyps present in pediatric years. Very often they pass before their person goes into adulthood. Sometimes these different hamartomatous polyps can cause problems. They can be excoriated, they can bleed, they can catch a peristaltic wave, and they can cause intussusception. They have no malignant potential. They're composed of normal cells, but the cells are just arranged in some sort of disorganized manner. And they make a little lump of the polyp called hamartomatous polyps. Now, again, usually, a problem like with this will present kind of in the younger years. And so they're discovered in juveniles, called juvenile polyps. Usually, because of the nature of the polyp and the way they're exposed in the lumen, fecal material eventually will kind of catch them. If they bleed, it'll cause problems that way, but they can also be eroded to the point where they actually detach from the wall and they're passed. And so usually at some point, if someone has a juvenile polyp, they'll go to the bathroom and they'll look down and they'll see this kind of fleshy mass. Like, that's just simply a past polyp. If they're not past in the juvenile years, and this polyp lasts into adulthood, they're called retention polyps. Retention polyps. It's the same juvenile polyp, just lasts in childhood and adulthood. Okay. Another example of a hamartomatous polyps develops in association with a genetic disease called Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is a genetic disease. It's based on a gene that's mutated in chromosome 19. People with Peutz-Jeghers syndrome have hundreds of hamartomatous polyps in their colon. In addition, they have some odd facial features. Very often on the lips and around the mouth, they'll have these melanocytic lesions. Take a look. Here's someone with Peutz-Jeghers syndrome. Okay, you can see the face here. Again, you'll notice on the lips, you've got these melanocytic lesions. Even around the lips, you've got lots of melanocytic lesions. This is typical presentation for someone with Peutz-Jeghers syndrome. A person like this would have a number of different hamartomatous polyps in the bowel. And again, these hamartomatous polyps, they have no malignant degenerative ability, but they still can cause extensive bleeding, it can cause tusseception. Questions on hamartomatous polyps? On neoplastic polyps. Okay, next we have the neoplastic polyps. These are the polyps we have to worry about. These are benign, but they're adenomas. They have neoplastic epithelium that comprises them. And the problem with these adenomatous polyps, these neoplastic polyps, is they have malignant degenerative potential. In fact, it's thought that all different bowel cancers, all these adenocarcinomas of the bowel, ultimately develop as a result of malignant degenerative changes occurring in these adenomatous polyps. Let's take a look at an example of an adenomatous polyp. Okay, here's an example of an adenomatous polyp with pedunculated morphology. Okay. The bowel wall would be here. You can see you've got the stalk, and you see you have a bed. Okay. Clearly got pedunculated morphology. Now, these adenomatous polyps have a very dysplastic epithelium. And as you know, dysplasia is the forerunner of cancer. It wouldn't take much for dysplastic epithelium to degenerate into a locally invasive cancer. Now, when we look at the polyp, usually the epithelium on the stalk isn't a problem. Take a look at the stalk. You can see the epithelium here investing the stalk, the core of the stalk. You can see just a lot of connective tissue and blood vessels. Usually the epithelium that invests the stalk is not neoplastic. It's usually normal colonic epithelium. The problem is up here in the head. This epithelium up here is usually dysplastic. This particular polyp has an overall architecture that forms little tubes. See little tubes here, cut down. And as a result, we call this a tubular adenoma with pedunculated morphology. Pedunculated tubular adenoma. Now again, the big problem is up here in the head. This is where the dysplastic epithelium is. Take a close look at this epithelium. You can see there is indeed a dysplastic epithelium in the head of this polyp. In this section, we have normal epithelium as well as dysplastic epithelium. Over here, you've got some normal epithelium. This consists of those columnar enterocytes with a microvillus brush border. All of the enterocytes look fairly well spaced. Okay? They look normal. They have relatively normal morphology. They're not crowding each other. Some areas might look a little crowded, but it's because the section is so thick and they have multiple layers of cells and overlap. Everything looks good over there. These cells sit on a basement membrane that separates them from the lamina propria. See here. Lamina propria. There's the base. Okay, everything's normal over here. center of the section, we have this dysplastic epithelium. There's the dysplastic epithelium. Of course, the membrane, basement membrane, and separating it from the laminar propria. Take a look at this dysplastic epithelium. Look at the cells. You can see how crowded they are. They're not supposed to crowd like this. They should not crowd each other like this. Their growth should be very strongly regulated. Cells should never crowd themselves. The fact that they are crowded indicates that this is a neoplastic epithelium, what we call dysplastic. You can see within the epithelium, you've got these are mitotic features. The cells are still multiplying despite the fact that the epithelium is very crowded. These cells should be contact inhibiting each other. They should not crowd each other. Now, this in and of itself is benign. You'll notice that the cells, even though they're over-proliferating, they are respecting the basement membrane right here. That basement membrane is a natural barrier. As long as the cells don't penetrate that natural barrier, these cells aren't showing any signs of local invasion, which is a defining feature of malignancy. However, it wouldn't take much for some of these cells to mutate and turn on maybe a laminase, collagenase, allows them to break through that basement membrane and start invading into the laminar propria. When that happens, this is no longer an adenoma. This is no longer a dysplastic polyp. This is a locally invasive adenocarcinoma. And it's thought that most adenocarcinomas of the bowel evolve from these benign adenomatous polyps. Just that these benign adenomatous polyps undergo degenerative change. Let's take a look at the radiographic appearance of some of these polyps. You can view these polyps a number of different ways. One way is to use a lower GI series. Here's an example of a double contrast lower GI series. Here we're using two contrast agents. We're using barium and air. See here, we've got lower GI series in this person's barium enema. We've asked the person to evacuate the barium, and then we inflate the bowel with air. So now we have two contrast agents, the barium and the air. First, the barium coats the interior of the bowel. Get that, evacuate all that contrast agent. The coating still remains on the epithelial surface of the bowel. Then we inflate the bowel with air, so we get this nice kind of pseudo 3D image of the bowel. Okay, you can see over here we've got the rectal wall. There, you can see the sigmoid colon right there, peristaltic wave right there, redundant length of the sigmoid colon. Got the descending bowel right over here, and of course we've got the splenic flexure over here. We've got the transverse bowel and lymphatic flexure. Take a look at the descending bowel, descending large bowel. You can see that we have a polyp. Rather sizable polyp. And it has a stalk. And it has a head over here, and that makes it pedunculated polyp. Now you can see it's a rather sizable polyp. It's taking a lot of room in that bowel. Now in this area of the bowel, fecal material tends to be solidified. Start to change from the pasty material to more solid material. Fecal material starts passing through here. It's going to excoriate that polyp. And so whatever that polyp is, at the very least, it's going to, and in this area, it probably will present some form of dark red blood stool as it's excoriated and bleeds. Now, this happens to be a juvenile polyp. That polyp is just a hamartoma. It's benign. It's not even neoplastic. It just consists of a lot of normal cells that are arranged in some sort of disorganized architecture. But nonetheless, that polyp is causing serious trouble. Now you can also see the polyp on a single contrast agent. We just perform a barium enema. This is what it would look like. Patient. And you can see the rectal wall here. sigmoid colon. Notice there's a lot of redundant length of the sigmoid colon. You can see now where you can get a loop of bowel like first right at its base. Very common pattern would be a typical volvulus to develop in this sigmoid colon because of the redundant length. Over here we have the descending bowel and transverse bowel. Of course, you have the descending bowel here, and looks like the appendix, and that looks like the terminal ileum. Look at the descending bowel, you got a filling defect. That's the polyp. Doesn't look as good on a single contrast study. You can really see a lot of the features, but nonetheless, you see it here as a filling defect. Okay, well, if that is causing trouble, we're gonna have to resect it. It's causing bleeding to the point where someone needs a blood transfusion. We're probably gonna want to resect it. Any questions on those polyps? Yes. Are hemorrhoids a type of polyp? Hemorrhoids are not polyps in the sense that they are a abnormal growth of cells. They are vascular lesions. They're actually very much like varicose veins. They are composed of very convoluted blood vessels that are distended. And as those blood vessels kind of expand, tissue develops around them, so they make these kind of tumorous masses called piles of hemorrhoids. I think everywhere else in the world they're called piles. Here we call them hemorrhoids.
Is that also a filling defect? No, part that's,
This,
yeah.
yeah, that's just an air.
Oh,
Okay, presentation for polyps. Again, many of them are asymptomatic. If they happen to be discovered incidentally and they're asymptomatic, and they're not adenomatous polyps, we just generally leave them alone. Non-neoplastic, they're asymptomatic, we just leave them alone. If, however, we discover that a person has polyps, whether they're symptomatic or not, if they happen to be adenomatous, we will resect them. And that's because they have malignant degenerative potential. So we'd rather resect them over benign lesions than deal with them when they're malignant. Other complications, again, they can present with torsion, painful infarctions. They can cause this by tussoception. Again, cold bleeding can cause anemia. Some of these different polyps, especially the adenomatous polyps, they have that dysplastic epithelium. That dysplastic epithelium tends to elaborate a lot of proteinaceous secretions. And sometimes a person can lose a lot of protein as a result of that abnormal epithelium just dumping rich protein fluid into the GI tract. They also have a tendency to produce a lot of potassium. And so sometimes a polyp can present as hypokalemia. You're losing a lot of potassium in the GI tract. Again, that's due to that dysplastic type of epithelium. So you can lose a lot of protein, a lot of potassium. Sometimes loss of protein might present with hypoproteinemia, hypoalbuminemia, and lose a lot of potassium and present with hypokalemia. Again, first symptom might be intussusception or even obstruction. So there are a number of different ways that these polyps present. Intussusception is when a proximal segment of valve herniates. Okay. Anything on that? Let's just cover the workup. Okay, very often we're going to screen to see if there's blood in the bowel. We do that for a lot of reasons. That's one of the screening tests for bowel cancer. If someone has a polyp, polyp might just be bleeding. Again, it's an exposed position. You get excoriated. You might follow that up with a flexible sigmoidoscopy or colonoscopy or maybe barium enema study. Also, a digital rectal exam. Usually, when we're performing a digital rectal exam, we're just looking for masses very close to the anus. A lot of different these masses, a lot of different colorectal cancers will develop right in the vicinity that's in reach of a finger when you're doing a digital rectal exam. While we're doing a digital rectal exam, we'll get a sample of fecal material. We'll smear that on a hemocult card, and we'll develop that hemocult card. And that hemocult card may turn a color that's indicative of hemoglobin being present in the stool. That's how we screen for blood. We perform what we call a hemocult test. It's a test that involves a little card. You take the card, you smear a little fecal material on it, and you develop a solution. If it turns blue, that means there's hemoglobin present. Called a hemocult test. Sometimes things go wrong with the hemocult test to be aware of. Sometimes if people eat red meats, maybe the night before you do a hemocult test, well, there's a lot of blood in that red meat that might turn the hemocult test positive, even though the person doesn't have a GI bleed. There's still blood in the stool, but it's not the patient's blood. Whatever. Just have to be aware of it. Okay. Any questions on this? Let's start taking a look at colorectal cancers. I mentioned before, most of these colorectal cancers are going to be adenocarcinomas. And it's thought that most of these adenocarcinomas develop as a result of malignant degenerative changes in a pre-existing adenomatous polyp. Adenomatous polyp is benign, but it has a dysplastic epithelium. And that dysplastic epithelium can degenerate into locally invasive carcinoma. Peak incidence for bowel cancers, typically between the age of 60 and 70. If someone develops bowel cancer before the age of 60, usually there's some sort of identifiable antecedent condition in the history. Maybe the person had ulcerative colitis or something. People with ulcerative colitis, they're going to develop bowel cancer. It's usually much earlier than 60, it could be in their 40s. And that's due to constant inflammation causing degenerative changes in the bowel, accelerate the whole process of mutation, and they can develop cancer much earlier.
What do you think the percentage of people with that turns into like cancer thing?
Ulcerative colitis?
Yeah, I have a friend that has that.
So I don't know the frequency of it.
Mm-hmm.
I have, from my personal experience, of maybe 20 or 25 patients that had ulcerative colitis, 3 of them developed. One was a young woman, age 40. Okay. All right, presentation. Really depends on where the cancer is developed. Sometimes a cancer will develop on the right side of the colon, sometimes cancer will develop on the left side. Where the cancer develops really determines the percent features of the cancer. If the cancer tends to develop on the right side, usually it can remain asymptomatic for a long period of time. That's because these colon cancers are very slow growing. Even when the cancer starts to occlude the bowel lumen, fecal material on the right side is very fluid, so it can get through these little strictured areas of bowel, and it will remain asymptomatic. It won't present with any change in bowel habits for a real long time. It only presents with changes in bowel habits when the stricture gets extremely small. And maybe the person will start experiencing constipation. When cancer develops on the left side, well, that's the side where there's solidified fecal material. Solid fecal material is going to have more difficulty passing through a stricture in the bowel. As a result, cancer developing on the left side of the bowel generally presents earlier than cancers growing on the right side of the bowel. That's simply because cancer developing on the left side of the bowel more likely to present with changes in bowel habit early. Also, these cancers tend to bleed when They bleed on the left side, it's more likely the patient's gonna notice some shade of red blood passing in their stool. Might be kind of on the side of the stool, or it might be drips of blood. They're more likely to notice it if it's some shade of color. All right, let's take a look at an example of bowel cancers. Here's an example of bowel cancer. You've got a segment, large bowel. It's been opened here along the longitudinal axis. We're now looking at the mucosa. Over here, you can see some normal bowel. You can see the large folds in the bowel. It's an increasing surface area for absorbing water. Most of the function of the bowel is storing fecal material and absorbing water. It's got some other functions, but those are the main functions. Now, in this bowel, you'll notice that there are some polyps. Polyp here, polyp there, polyp there, polyp here. These are probably adenomatous polyps, probably benign in and of themselves, but they do have a dysplastic epithelium. The problem with these polyps is that they can undergo malignant degeneration. That's probably what happened here. Here we have a malignant adenocarcinoma presenting as ulcerative mass. You can see you've got this kind of crater here, and then you've got these heaped up margins. That is a ulcer that has classic malignant morphology. It's got the crater inside, it's got the heaped up borders. Now, this cancer, is ulcerative mass, is kind of growing in an annular pattern. It means it's growing around the inner circumference of the bowel, all around the inner circumference of the bowel. It's got an annular distribution all around the inner circumference of the bowel. As it grows, it's going to protrude into the lumen. You can see it's going to cause some obstruction, at least stenosis of this bowel. Again, depending on what side of the bowel this is developing on, right or left, will determine the presenting features. Develops on the right side, it's not going to present for a long time with bowel obstruction. It's developing on the left side with fecal material solidified, it's probably going to present a lot earlier with some sort of changes in bowel habit, also some noticeable red blood in the stool. Now, the cancers growing on the right side, they tend to grow slowly, but they can present with some other vague symptoms. They may be fatigue, some other very non-specific presenting features. It's very difficult to narrow down to the bowel cancer. You kind of have to do a screening process somehow to identify that there's blood in the stool. And if you do that, well, that might set you wise that there's some sort of polyp or cancer growing in the bowel. Let's take a look at histology of this cancer. This is a section through the musculus propria of the bowel. It consists of lots of smooth muscle cells. Smooth muscle cells. And those amongst the smooth muscle cells, we have these glands, and they're very atypical looking glands. Looks like these glands are eating their way right through the musculus propria. That's the adenocarcinoma. Adenocarcinoma, is malignant proliferation of glands, and there it is. Got lots of glands. It's a good example of one of the glands of the liver, the adenocarcinoma. Let's take a quick look at the radiographic appearance of bowel cancer. This is one way the bowel cancer can present. It's going to be a bowel cancer developing on the right side of the bone. So it's going to present very late in the development. Most of these are pretty asymptomatic until they get into the advanced stages. And this is a barium enema. Again, you can see the rectum over here. Okay, there's the sigmoid colon right over there. Look at how much redundant link you have in the sigmoid colon. That's why a volvulus was developed. Got descending bowel, transverse, and you got, of course, the ascending bowel right here. And you'll notice just distal to the ascending bowel, within the transverse bowel, you've got this big filling defect, very large filling defect. That's a cancer growing with an annular distribution. It's growing around the interior of the bowel, protrudes into the lumen of the bowel. It's causing displacement of this pretty opaque dye, resulting in a filling defect. Now, if you look at this filling defect, it might remind you of an apple after it's eaten, core remains after you eat the apple. That's called an apple porridge. This is an apple porridge. Okay, what's going to go on here? Well, it's obviously an advanced lesion. Look how narrow this wound is. I mean, now we're just discovering it. Okay, that's pretty advanced. You can get away with a lumen this narrow only if the fecal material is very fluidic, piece squeeze through there and make it to the rectum. But this cancer developing over here, it would never present this advanced. It would present much better. Now, just judging from the looks of the large bowel, it looks like this person was indeed presenting with some changes in bowel habit. Look how distended the ascending large bowel is compared to the transverse colon. You can see this in the back. So this person probably just beginning to present with some changes in bowel habit. Any questions on that? Okay, so some common things that we need to consider. And we mentioned that very often these cancers will develop at a certain age, somewhere around 60 to 70, that's where most of them develop. Anything younger, they're probably going to be an antecedent condition. Most of the time, these cancers are bleeding, and whether the blood is recognized or not, the person is losing blood and losing iron. And so very often, one of the common presenting features of a bowel cancer is iron deficiency anemia. Iron deficiency anemia. It's so common, in fact, that if you have a man in the age range of 60 to 70, and they're presenting with an iron deficiency anemia, the diagnosis is bowel cancer until we rule it out. That's how common it is. That's how common a presenting feature it is. First have to identify if the person's bleeding from the GI tract. We have to do a Hemocolt test. If we find the Hemocolt test is positive, we're going to have to follow up with some sort of imaging study. A Hemocolt test is a way to test for hemoglobin in stool.
Doctor,
Yes.
would a patient like this also present with change in appetite and body mass?
It might tend to nausea. And they'll have, they may just have cachexia as well. Depending on how these cancers start. Okay, I want to go over time. Finish this up next time. Any questions? Yes.
Just an estimate, when are you thinking the next exam would be?
I'm gonna have to take, because we only have
4 weeks after.
4 weeks after this. And semester is short. I'm gonna have to look at the logistics of things. We'll have to have some.
Yeah, I figured that's why I just wanted to talk about it today, so everybody was at least ready.
Well, I'll let you know when I know.
Fair enough. Thank you.
Anything else? Right. Today.
Let's buy a vowel. How about an A?
Take that.
He's gonna have to cut. He's gonna have to cut material out of the last section.
I think he's gonna have to,
Huh?
because it's a lot of stuff.
Yeah, it's got female system, male systems, and whatever the primer is of that.